So I'll try to make this real quick, and I don't have a PowerPoint presentation to put up on the screen. So essentially, what I'm here to do in this section is to give you some of the framework about the 225, the ground ambulance licensing, and the sustainability task force. And I'll begin, kind of funny, because what you name things matter, and how they take your name and put it into the acronym. And in 2022, when we came up with Senate Bill 225, called it the Ambulance Service Sustainability and State Licensing Task Force. I'd never thought of it until I ran into Senator Janal, and she says, "Oh, you're here to talk about the AS bill." So, you know, even when you think about it, I mean, it did become a joke with us throughout the Capitol, and we'd be talking to other representatives and senators. It's like, I'm here to talk to you about the AS bill. It was funny because they knew exactly which one we were talking about when we came up to them. And a lot of that goes back to our relationships that we built to even be able to joke with them about stuff like this. But 225, the Ambulance Service Sustainability Task Force, I'll give you a little bit of background on even why that got started in the first place. Do you remember anything at all, or a major event that happened maybe in 2019, 2020, that kind of rocked our world?
Was it in
I can't think
Aurora?
of anything.
Yes, the Elijah McClain case. The Elijah McClain case kind of rocked our world in EMS. For right or for wrong, it rocked our world. And while we were going through that whole legislative process over that individual bill, one of the things we kept hearing was, how come the state doesn't do anything? How come the state didn't do anything? How come the state didn't help keep this from happening? Where was the accountability from the state? Literally, the state said, there is no accountability from us from that standpoint. And some of these legislators did their homework. Well, every other state in the nation regulates ambulance services. Why don't you? Well, because we don't. That's the way the statute's written. It's a county responsibility. But we got to do something about that. So even when we started approaching what 225 could be, should be about, we wanted to do something before they did something about it, because if they did something about it, it would be absolutely no good for us in how that bill came down. So that's kind of the background on where 225 came from, and it started off with the discussion of ground ambulance licensing. And then there were those of us at MSAC who were going, whoa, wait a minute. Well, we understand kind of why you want to do this and the importance of it. But new regulations equal new costs, cost creep. Of all the things that you may require us to perform as ambulance services, if we don't even have the funds to do what we do every day, how are we going to pay for some of the funds that ground ambulance licensing may put upon us and may require us to perform and do? So we have to do something to try to identify the strengths and weaknesses of the system, and how are we going to try to change it over the long term? And what could a potential long-term plan be? So essentially what 225 did was, by January 1st of 2024, the Board of Health has to pass ground ambulance licensing rules. That was the first component of 225. And the other component of 225 was it gave us the opportunity to do at least an initial environmental scan. That's a fancy term of a kind of a survey and a report, to try to identify, where are we now? And so throughout most of last year, the state set up well, I'll back up a little bit. So that was the first components, and there's actually 5 components to the bill. The first one was regarding the regulation of ambulance services, ambulance service licensing and performing the environmental scan. The second part of the bill was to address inequities and disparities regarding access to emergency care. And I think a lot of the stuff is going to build on stuff that we do each year. It's going to kind of follow through into subsequent years. Because even when we were doing the environmental scan, we talked about finance. What was wrong with the finance? We talked about where's the recruitment and retention right now. We talked about, are there any ambulance deserts in Colorado right now? Or are there any disparities in primary health care that maybe community integrated health could address? We talked about a whole bunch of different things to try to identify where we are right now. And we do have a report out. If you haven't seen it yet, it's on CDPHE's website under the Sustainability Task Force. The first report is done. Because what we have to do with each one of these steps is we have to report back to the legislature of what we found and what our potential recommendations are. So year 2 is trying to address the inequities and disparities. Are there any areas that have access to care issues to ambulance services? Well, I can tell you one area right off the top of my head that is very glaring, and that's the northwest corner of the state, up there in the whole dinosaur area of the state of Colorado. The ambulance service is provided out of a private company out of Vernal, Utah, because there's no ambulance service in that area. And ironically, there's a huge national monument up there that has a high tourist, high river rafting population that goes through there every year. And there's no ambulance except the one in Vernal. Luckily, Vernal's closer to that area than a lot of the other communities, but that's one clear example of one of the inequities. So throughout this year, we're starting to talk about inequities. We're starting to talk about some of the stuff we want to look at. The interesting thing about the committee itself that's set up, and it's a SEMTAC committee, is our chair and our vice chair are both legislators. So Senator Baisley is the chair of the Sustainability Task Force, and I'm trying to remember, Armgas left, and it's now Kyle, Representative Kyle.
Yes.
And what's interesting is that the two legislators can't be from the same party. There has to be one Democrat and one Republican. Baisley is the Republican, and Kyle is the Democrat on the task force. Well, what happens about January 10th, January 15th? They all go back to the Gold Dome. And while they're in the Gold Dome, they're doing their work with the people that elected them to go to the state capitol. So their participation kind of pauses, if you will, because they can't focus on what we're doing. But that's where we break off into our subgroups. And our subgroups. And the primary subgroups that are out there right now is the finance part. And even when I think about how does finance impact the access to care? Another one is EMS education. How does our inability to educate our providers impact access to care? Recruitment and retention. How does all that impact access to care? And then governance. There's a whole group that just talks about governance. And what should change on that? And how does that impact patient care? Next year, we'll be specifically talking about the workforce shortage and how we can improve the workforce shortage. And talk about those same categories. How does finance impact workforce? So on and keep going through those topics. The one that I'm most interested in is year 4. How do we promote or advocate for financial sustainability in EMS? How do we take a look at all the various things? How do we fund EMS in the future? We know that the current model isn't working. We know it's a failed financial model. And we know that treatment in place is not funded. And we know that mobile integrated health is not funded. I mean, that's what we know right off the top. And we know that transporting the patient via the most expensive means to the most expensive place probably isn't the right model to do either. So even when we talk about the financial component, how does it impact governance? How does it impact education? How does it impact all these other things? And what are our recommendations for the future? How do we sustain EMS? And then the last year is kind of the whole recap. What is the big picture? What is the ultimate strategy for what we want to do, especially from the funding side? Because I think all throughout the process, we're going to pull out individual components and identify specific recommendations that we will want to take action on in that legislative cycle. And we're already starting to identify funding shortfalls, for example. And what we're talking about doing even for this year regarding what we saw, what we modeled, and even looking at what some of the other states are doing, it kind of goes back to what Matt talked about. We may introduce a bill. We already have a House and a Senate sponsor. All we got to do is frame the bill and what we want to do with it. But we may go with the local advertised rate. The commercial payers have to pay the bill charges and the commercially advertised rate. Why is the local advertised rate so important? Because what it costs to provide services in Colorado Springs is a lot different than what it costs to provide services in Woodland Park, which is completely different than what it costs to provide services in Gunnison Valley. And it's different than what it costs to provide services in Grand County. You've seen one EMS agency, you've seen one EMS agency. So the requirement may be that EMS agencies have to publish with, like, the Division of Insurance once a year what their rates are. And even when I heard Matt's conversation yesterday, remember how it's like you got first dollar coverage? I've been in some phone calls in between that with some other folks from Texas, and it's like, it's not necessarily what happened. But what they did get, which I think is huge, with the local advertised rate was the insurance company has to accept that those billed charges to their plan. And therefore, they can still apply their deductible and co-insurances to that. When you bill, and it's funny because they're like, we don't talk about balanced billing anymore. Balanced billing is going away. What we're billing for is the deductible and co-insurance. And it falls within the plan that they chose. That's the amount that they ultimately we want to try to collect, are the billed charges. The cool thing about that, though, with the billed charges is, once you get beyond the deductible and copay, so even when you think about it, a lot of patients with all their healthcare services that they're paying for will be paying incrementally throughout the year to meet their deductible and co-insurances. And as they do that, the amount that the insurance will pay regarding an ambulance service goes up throughout the year. Because once they've met their deductible and co-insurance, then they have to pay the billed charges. That make sense?
Mm-hmm. What is the local advertised rate? Sorry to use that a couple times.
Local
Is that
advertising.
what the hospital has to advertise now per the law as their cost of MRI or cost?
No, that's the amount that the hospital will advertise for the cost of their ambulance service, or the charges for their ambulance service would be with the local advertised rate for Gunnison Valley Hospital.
Got it.
Same thing for Grand County EMS. When they turn it in, that would be the charges for Grand County EMS, just like mine would be for UTAS Regional Health Service District.
So would that still be related to the CMS maximums, or
No,
how would we
no,
set that?
This is what it costs you to
so what
provide
it
care.
costs you to
Okay.
provide the service, and what I would say that we need to be prepared for, because some of the questions that we could get is, how does each of those agencies come up with their local advertised rate? And if you come up and say, well, he charges $1,500 for his ambulance and you charge $1,600 for your ambulance. And when you're looking at the rate, it's like, well, oh my God, I don't want to be way over him. Well, she's higher than him, but that's the cost comparison method, right? That's what a lot of services do nowadays. To me, my system that I showed you on the screen yesterday, trying to remember the term that they use. Somehow they say that is price fixing. If I'm basing my charges on my costs, how can that be price fixing? I think price fixing is colluding
Comparing, yeah.
with each one of you to say, all right, so my charge based on your threes, which has nothing to do with the costs, I'm going to charge $1,650 because it's between yours. And but it doesn't make me stand out as the price gouging ambulance service. So I know that was a long, convoluted answer to the question, but I think we need to be prepared for how do we determine our rates? And even if you came in and you did nothing more than look at your expenses divided by the transports, or your budgeted amount, divided it by the transports and say, it costs us $2,600 to run the ambulance out the door. That's what you should use as your local advertisement. Some people are going to say, well, it doesn't matter how much I raise my rates, especially with my Medicare. It's not going to change my reimbursements all that much. Part of our problem is the insurance companies have data on us. And part of the reason why we're not getting increases is because we're not charging our costs. And so until we actually, in fact, I think it's called the usual customary, until we started impacting that, we're not seeing increases. So bringing it back to the 225 conversation, that could be something that we come up with, somehow tying that back to an essential service. But I want to be really careful with that. We may not actually, Tim's opinion, there's a lot of people that want to go for essential service designation next year. Essential service means nothing if there's not a funding mechanism of some sort tied to it. Absolutely nothing, because there's nothing essential about something you can't pay for. So I actually think that making the essential service should be maybe in year 5 when we come up with whatever that big idea is. But we may also tie into it. You got a question?
No,
Kim?
I just wanted you to finish your earlier comment on the legislation, because if you don't publish your rate.
Oh, so the other thing that would go along with that is in following Texas, and that's a cool thing because it started right here in Colorado. Is the 325% of Medicare. So if you're a small service and you don't publicize your rates, that's the floor. Is 325% of Medicare, which is what Texas. Because even when I asked Matt, how did you come up with 325? Because that's what Colorado did. Colorado set the standard for that. And I could tell you a whole other story about how we arrived at 325.
I don't understand what that means.
That would, what the 325% of Medicare is?
Yeah, I don't
So you take your 325% of the Medicare payment. If you pull out your calculator to figure out what that is, that's a lot more than what you probably.
What is that, a penalty if you don't publicize?
Yeah. No, it's not, well, you could potentially say, yes, it is a penalty because you didn't certify your rate, but it's a protection for some of the small services that you at least get the 325%.
It'd be the minimum you would get. The minimum you would receive.
Yes.
325% of the Medicare allowable for every patient
But you transport
that you transport. Yes.
would become the accepted rate.
If you don't publish
If you don't
your
publish
local advertised rate.
your local advertised rate. So that's kind of what we're thinking, the kind of the direction we tie in tip and maybe even MIH, we're not certain yet, tip being treatment in place. Some of us don't want to, some of the group don't want to confuse tip with the base payment. So there could be two bills to try to get treatment in place back. And even if we got treatment in place, well, what's treatment in place for? Is it the Medicare allowable rates minus mileage? I mean, even if we got that, that would be huge. Even if you think about you going and evaluating and treating a patient BLS level, and you could get, what is it, $325 for a treatment in place? And then maybe if you do at least 1, 2, or 3 ALS skills, you get that diabetic that you go in and you evaluate, start an IV on them, give them some sugar, you wake them up, they now refuse. Well, that would be billed at an AS level charge, minus mileage. Well, that would save insurance companies a lot of money because they're not paying the mileage rate.
Not paying the hospital.
And you're also not paying the ambulance-based rate and charges, and you're not paying the hospital charge as well. So,
Tim does a really good job with this. The concern that continues to come up for some is that, wow, that seems like a lot. But is that the number we want to use, or do we go higher? That's like when the discussion about 325% of Medicare, there was a lot of discussion in the room. Is that the right number? Because it was truly just a pulled out of the air, wasn't it?
no, it was not.
It was
pulled out of
not,
the air.
okay.
Now feels pretty good.
It was not. You want to hear that side of it? It's a little off of the 225 task force, but this is really what happened. So a few years ago, Representative Escar really wanted to address the consumer concerns about surprise billing, not just surprise ambulance bills, but surprise billing in general. And she was really stuck on this network rate, in-network rate. Well, we know that the network rate, the most in commercial payers is trash, to be quite honest with you. And so there were two perspectives. MSAC proposed, as an amendment to this bill, what we wanted was to negotiate with the insurance carriers, which we haven't been able to do. We're asking for an equitable process to determine an equitable payment that was equitable to the providers, the payers, and the patients. So that would have given us the opportunity to negotiate, whether it was with the carriers themselves or if it was the DORA, Division of Insurance, DOI DORA. Fire chiefs on the other side said, oh, no. That's too risky. We don't know what that means. We want to just be exempt. We want to be able to continue balanced billing. We just want exempt. Because we are different, and we are, than most other healthcare providers. So when we actually get to the bill, both provisions were included in that bill, which complicated it dramatically. So we actually get to the DORA rule, the bill passed. We actually get to the DORA rulemaking process. And especially Chris Montero, we were throwing out some incredible numbers. We want first dollar coverage. That's what we'd like to do. Or even a percent of first dollar coverage. Well, that was kind of off the table because that would rock the boat with the carriers too much. And then it was funny because we said, well, what about 425% of Medicare allowed? Well, the carriers in the room, they were silent. What Dora said was, it would be irresponsible for us to go to 425. Oh, well, I'll finish this statement and I'll tell you why. 425% of Medicare would be irresponsible for us to establish because the services that it would impact aren't even charging 425% of Medicare. But what we would be doing is arbitrarily setting up the ability for any service to just increase their rates to 425% of Medicare and get paid for it. So we don't know our costs. We don't know what we're billing. We do our, how much are you charging? We do our rate comparisons. So even though that could have been on the table, it wasn't. Well, let me back up just a little bit. In the bill, the fire department said publicly funded fire agencies are exempt. What Dora did was they said they focused on the publicly funded part and said every publicly funded service was exempt from the bill. So we just continue doing what we're doing without any changes. What they did though is say that anybody else, doesn't say carriers may pay, could pay, should pay. The rule says that the carriers shall pay 325% of the Medicare allowance, and that applies to the private provider. And it's funny because I've discussed that with several private partners, and they're like, no, it doesn't. It's like, pull up the rule. Look at the difference between shall, should, could. The rule says shall. Pay 325% of the Medicare allowable rate. So even, I don't know, I think it wasn't Platte, was it Platte Valley Ambulance? That was in that last Channel 7,
Oh, North Glen.
North Glen
North Glen's
Ambulance.
the one that got beat up.
Yep, I don't know if any of you saw that news article about North Glen Ambulance. The patient got like a $1,500, $1,800 ambulance bill from going from the medical office building next to the hospital to the hospital. They got a $1,500 ambulance bill, $1,600 ambulance bill. Obviously, the ambulance service was gouging the patient. Well, the interesting thing to me is even when I was taking a look and watching the news story, and they paused on that part that the insurance paid, and I made it bigger to see what the insurance actually paid. It wasn't 325% of Medicare. And the other thing is, I don't think the ambulance service or us as an industry were good enough advocates for ourselves to say, you know what? We don't have the block away charge. We kind of do. But we really don't have the block away charge versus the crosstown charge versus the other end of the county charge. We have very few charges that we can charge based on the AO, midnight, whatever the code is, which is base rate based on ALS, emergent, non-emergent, ALS, blah, blah, blah. Those are it. And we establish a base rate. But you're right, we do kind of have that next door because we have the mileage charge. And they didn't get charged. They only got the charge for the mileage that they actually consumed. Well, that wasn't brought up in the conversation. And maybe that was selective reporting. We know they do that. And the other thing was, I know that there's a change in the workers' comp reimbursement. Can't remember what the amount is, so I won't say it right now. But I know it was higher than what the insurance paid. I was able to calculate 325%, and I was able to look at what the insurance paid. It's like, so these groups are saying I can get this amount. The insurance company paid that amount. They didn't even pay what they were supposed to pay. So, I mean, that was a whole interesting process, and I'll bet you North Glen Ambulance had no clue, unfortunately. But I'll bet you most of you in this room don't have it, the idea. So they weren't even there. They weren't even their own best advocates for themselves on how to do that. And see, and for me, once again, when I go back to my presentation, Channel 5 would show up at my door. I have a process. I can show my costs. I can show how I figure my bill. Whether they like it or not, I don't like charging a patient $2,600, $2,624. but I can clearly justify what it is that I charge, based on a system that I can even say I pulled out of the American Ambulance Association book. I can quote the book. I can tell them the page number that they can look at that I established my standard. But yeah, we're getting close. I'm standing between you and the door. It's almost 5 o'clock, but long story short, like I said, we're starting to meet again. I think our next meeting actually is
November 8th. I think.
November 8th. And you can find if you go to the Sustainability Task Force, you can find the links to the meetings. We need you to participate. We need to hear your issues so that when we're determining the long-term strategy, we're doing it with the best information possible. So 225, ground ambulance licensing is almost done. I think it's the first time that I can remember, because we've got, well, Austin's been part of the conversation. There are some really, my perspective, and a lot of other providers' perspective, is a lot of cumbersome, really expensive rules in the ground ambulance licensing rule set. Rules that they say, well, we're not even really going to enforce. Partly because they don't have the money to enforce them. And second, because they're saying we're the kinder, gentler regulator. So we're really not going to take anybody's license away. I mean, we'll help you however we can to get you into compliance. But our position, at least from MSAC, is doesn't matter what you choose or don't choose to enforce. Those are the rules. And even if you choose not to enforce those rules, there's civil liability based on any service that doesn't follow the rules for whatever reason they do or don't. And then when the state says, well, what part of the kinder, gentler message didn't we portray in all those meetings? Well, I said, what part of the message you're doing too much? It's overreach. You're putting things in the rules we can't pay for. What part of that message that you didn't get? Well, they did capitulate and change on a few things. But all in all, the bulk of the rules still stayed there. But the CEMTAC meeting that they were really hoping to get the bills passed or get the rules passed, they didn't pass. There was actually a motion to set up a special CEMTAC meeting, which I think there's gonna be one the 8th or the 9th of next month, where we're gonna start talking about these again. And I know that section 9 has received, which has to do with medical direction, mandatory reporting. That's been revised. You'll see that soon coming out. Also know that section 14, which was a lot of the rules related, has been amended. We're going to be sending that out for everybody to see before the CEMTAC meeting. MSAC is going to be sending that, and then sending it to CDPHE, and it'll be available on CDPHE's website as well. Because for us, it's like we literally went from 0 to 60 in a year regarding ground ambulance licensing regulation, and we're not ready for it. I mean, especially if and I don't mean to sound like I'm fishing on small rural services, but if I was like in, I don't know, Haxton, Colorado, and my primary job was running my ranch, and my benevolent portion of me happens to be being on the Haxton ambulance, and I'm the administrator, maybe because I'm the person that missed the meeting and I was elected, or I want to be the chief because I care about my community. I want to get the ambulance out. I want to do the best thing that I can do to provide the best care. And then we come and hit them with all these regulations and all these things you got. I mean, just to get the license. I mean, at what point does somebody in rural Colorado say, here's the keys to the grant ambulance, the grant funded ambulance that we got, good luck with that. Now, I don't know if they'd actually do that or not, but when you go from one extreme to the other, it's like, why don't we start off as something basic, to get it off the ground. And then we grow the rules, maybe every 2 years, we reevaluate them and say, all right, let's add this component. Let's add that component. For the rule to actually make them better, but I think, as Sean Caffrey put it in the Suntech meeting, it was over. We had policy people in the background putting more words on paper. And we couldn't get them changed.
So if you want to follow what's going on, you just go to the state's website, which is coems.info. You scroll down.
Sharing this with the folks on,
Yeah,
Okay.
it should be on there.
Okay.
Well, I may not be. Oh, I'm not sure if there's anybody even left on there. Engage with us. And the state we complained early on that there was just too much going on. And what's really frustrating here right now is that the meetings which Tim and I have already talked about should be going on, they're not on here. I swear the next sustainability meeting is November 8th, and I see there's the task force there, but
that's gonna be right after that. Hold on, I need to talk about that.
this has been fairly up to date. So it's really easy to see where they are. Plus, this is also the place where you can find what all's going on.
I think the important thing to mention to people who aren't participating in the stakeholder meetings is that the state is doing the absolute bare minimum to comply with it, like the core requirements of these meetings. There aren't minutes, the recordings aren't publicly available, so if you're not attending the meetings, you're missing something.
And the only thing you see is all the revisions that have been done in between. And
And the
there's a
day
lot of-
before the next meeting, not time to.
Literally, and even the rules when they came out, the Suntech review was 2 days before. So when you have a bunch of Suntech members who aren't EMS folks, even if you took the time to read the rules, you really don't understand it, and they may make sense. I mean, there's a lot of stuff in the rules that I actually agree with, that they put in there, that I'd like to see us comply with. But when I think of us collectively, when they're writing it to be us collectively, I think we need to have more flexibility. I think you had your hand up in the thing. No, thank you.
So I want to, first of all, I want to say that I have a spot in my heart for the policy walks. I really do love those books. But what you're talking about, I am seeing as a consistent trend and have seen a consistent trend across the state, across the various agencies, where the policy walks kind of go behind closed doors and rewrite what the panels put forward in the first place. And that lack of transparency is a really good point. My question is there any mechanism for forcing involvement from folks who aren't the policy walks, who aren't the attorneys that are rewriting these things, or the master's level legal studies that are rewriting these things and saying, hey, we want to be part of it?
So generally, CDPHE does it in the past, of course, especially staffing projects, has done a good job with the provider stakeholder engagement process. So I've got to give them that. And I think the policy folks were following the facility standards when they were writing this. And to specifically answer your question though, when those rules got to Suntech, we did not approve them.
So that's the that is the final, like you have the ability to say, nope, this isn't.
So the process is, the Board of Health has to approve the rules by December 20th. So that's when their hearing is. They already have these rules. This branch sent them the rules that we never saw. But they can't act on them until Suntech approves. That's what the October meeting was about. They didn't
Approve them.
They didn't approve them nor deny them. They said, we're going to do more work on this. It was not a popular decision at the branch level, but it was the right thing to do.
No, I don't think it was a surprise to them, because I think there's
The politics here are gonna be really fascinating to watch play out, in the sense of, it is in state law that the Board of Health will approve these rules
By December 20th, that's right.
And it doesn't matter what rules they are, they're approving them by law, but they can't approve them unless Simtac approves them.
In Title 25, 3.5, that's that.
And so
Says
there
that
is a very,
Simtac has to approve rules.
there's a competing set of laws that are fighting with each other right now. It's gonna be really interesting to see how that plays out.
And what I would like to see play out is, let's come up with a reasonable compromise. Because even the policy folks, even Randy said, this is the first step. We can go back and review and change whatever we want, but let's not make them, it's really hard, I think, to take things out of rules.
Yeah.
It's easier to put things into rules, add to rules. Kim?
And several of us in the room have been there from the beginning of this. We've heard that comment, that this is just the first set of rules. We will be able to, right, and we've heard we won't enforce them. Okay, how comfortable am I that you send the rules through, they get approved, you're not going to enforce them, but that's you saying it. Now there's a new person in the branch who says, hey, look, it says right here. But Tim brought up an even bigger point. Even if they consistently said, we aren't going to enforce this rule, what if something happens to his service and a lawyer says, well, it says here in the law that you have to do this.
That was one of the rules in there at one point was that there would be $500 fines for services per day of non-compliance. And they're like, we would never do that. Well, then why the
But then
hell is
why
it
is it even in the rule? Oh, then you're getting me all worked up again.
One last thing I would point out is that the DHA had rules that they were around 2765, they were supposed to complete the 2765 rules by August of last year, and they didn't get that done on time, and the world didn't come to an end, so what if not?
But the flip side is those 2765 rules, when they did pass, kind of passed in the dead of night. And most EMS administrators that I've talked to in the state who aren't the ones who were all in the same meetings had no clue that our statutory authority changed on July 1st. Like most EMS providers in the state have no idea that they can replace somebody. Oh, yep, that's where the system is completely failed.
Secure transfer. And if you want to learn more about that.
So anyway, I think a good question came up. What if we don't pass the rules? I think it's a high cost if we don't pass the rules. Because we went to the legislature and told them we wanted these rules. The legislature, especially our champions, they capitulated with us and said, we get it. I'm afraid of the cost of failure if we don't get something passed by December 20th, even as far as our credibility goes in the legislature. And I think we have a reasonable compromise path to present to everybody to consider and for Semtech to consider so that we can meet the December 20th Board of Health. And that's ultimately what we want to do. We don't want to piss off the department. We don't want to piss off the providers. And we especially don't want to piss off the small providers. We want to have a fair set of rules that we can live by.
Is there a way, as you write these rules, what I kind of hear it sounds like is that it's the realm of unfunded mandates, right? Here's the new mandate. Can you write into the rules and the policy, like funding mechanism in a way to say, hey, rural mom and pop county ambulance, these are the rules, but we're gonna give you an agent, a person who's gonna walk you through and help you be compliant. So it's not just this unfunded mandate.
Well, that was part of what the whole plan was to have the department folks. And even when I think of RETAX and even when I think of MSAC, that's an opportunity for us to get agency members and even individual members into MSAC. Is what if MSAC wrote a lot of the rules? And we put those rules out and made them available to MSAC members, whether you're large or small, and say, here's your personal policy. Change the name, protect the innocent, cross your heart and hope to die, stick a needle in your eye and go for it. I mean, I see some really good opportunities for that as well.
The problem was, I think there was good cooperation and collaboration at the beginning.
Mhm.
The problem was when there were issues that came up, there were no good faith efforts to modify. They just kept pushing them through.
It was, we'll get back to you next meeting.
We'll get back to you next meeting, and there was no changes. And that's when it just got to, it was not right.
So anyway, I'll end by saying we're in year 2. We're gonna really start talking about those factors that impact access to patient care, especially as it pertains to EMS. We'll see what we come up with. More participation that we can have in those meetings, the better understanding that we'll have, the clearer message we can send back to the legislature. Because remember, part of the reason for the 5-year program, and part of the reason for breaking up these issues, we're moving the legislature throughout these 5 years for whatever we think of might be the funding goal. And I'll just give you a tidbit. It could be a potential funding mechanism. What if we could approve a statewide sales tax of 0.5% or less? And all it did was it applied to rental cars, hotel rooms, Airbnbs. We have 83 million people who visit Colorado every year that consume ambulance services and don't pay for it. What if we could just target those people? And if we put that in front of the voters, they very well may approve.
Hopefully that doesn't take 5 years to get to that conclusion, because we know we need that.
Well, part of what we're doing too is, and Kim showed you one of the meetings, is there is a task force that was set up through EPNF, and SEMPAC approved it and set it up. We're gonna really start talking about the HUTF. And what the HUTF, well, not only do we have to fund the ground ambulance licensing that was passed, but we know that medical direction has no support, because, I mean, that's been a failed project since it started. Good idea, but it has no funding, has no support. We know that quality management throughout the state is a train wreck, because it has no funding, it has no support, it has no direction, it has nothing. We know the grant program is failing. We know that our RETACs do amazing work for us every single day, every single month, in supporting our services. Kim is amazing for us, Plains Beach RETAC. They were set up, and even if it was set up with adequate funding back in 1979, that funding isn't adequate enough to run the RETACs now. So we're gonna be talking about it.
It's a couple step process. So the HUTF conversation starts in 2 weeks or next week, what day it is. But it's not till year 4 of the task force that we actually start talking about the true funding of this and then how to make it sustainable.
One thing that bothered me about the design, because we know that we're in crisis. What's it gonna look like in 5 years?
I know.
The shit, we're hanging on by a thread every day.
Part of the problem though is we have to educate the legislature.
No, I understand that.
So we get what we want,
I understand that.
and we can't go into cost on this, especially if we ask for some sort of statewide something or another to help fund EMS. We have to have our ducks in a row and go for it, and well substantiated. And because I want to make those to committee. I mean, it's funny, we joke about the magic math, the legislature in the state of Colorado, it's something along the lines of 32, 15, and 1. And 32 possible House votes for the bill to pass that. 15 or 16, 18 Senate votes, and 1 governor.
4 years to get your ducks in a row is a long time of organizing ducks.
Well, I gotta tell you.
They are rabid, untrained
Well,
ducks.
but I gotta tell you, I mean, as an industry, we're pretty disengaged with our legislature. We are disengaged.
Yeah, we are.
At the
You're right.
national level.
You're right.
I mean, there's only a handful of us that reliably, consistently, and part of it, I understand, it's really difficult for you. If you got a phone call from Chris House that said, this bill's coming up, and it's gonna be heard this afternoon, and I need you to testify, first of all, I don't even know what I'm gonna say when I get there, but it's like, drop what I'm doing in my job, sitting in my car, putting on my Marion and Marion clothes, I'm driving up to Denver, getting into the committee room, signing up for the piece of paper, still don't necessarily know what I'm testifying on or what I'm gonna say, but I'm there.
And we're appreciative that you have the knowledge and the background to be able to do that.
But,
because
and
you
I'm
get
not
stuff.
trying to, but when we actually get to see, and that's one of the things that frustrates me about MSAC, that's the same thing that I love about MSAC, is we're a struggling organization. We have so much potential, but we can't even get folks to join MSAC as individual members, let alone agencies. And before you become effective, you have to have the staff to help you get the work done. I mean, when you think about your individual organizations, you have staff to help, you. Even if it's crews doing supply, or crews doing vehicle maintenance, or crews doing facility, coordinating facility stuff, at least they're helping. I mean, MSAC, I mean, we're doing better than we've ever had before, but we still don't have the support that we need to really make us. I mean, it's funny because as far as the legislature knows, we have 5,000 members, and I mean, we're known at the Capitol. We walk in, people recognize us. You're with MSAC, you're with the EMS folks. And we have, I won't necessarily say quite yet the same impact that the chiefs do, definitely not the CPFF. CPFF, to pass something at the legislature, you gotta have CPFF, Colorado Professional Firefighters. IAFF, you have to. So they're the most organized, and they actually have a